let me introduce Jess to everyone today. So Jess is a clinical neuropsychologist, an occupational therapist, and a lecturer in the School of Psychological Sciences at Monash University. And she's a researcher at the Monash Epworth Rehabilitation Research Centre. Now that's a really long sentence, but I think I got it all right. So she has a strong clinical background, having worked extensively in rehabilitation following acquired brain injury. Her research is grounded in clinical practice and focuses on developing, evaluating, and implementing rehabilitation approaches to improve evidence-based care, early recovery, and long-term outcomes for people with brain injury and their families. It's another really long sentence, but I think I got that one right too. This includes a focus on rehabilitation to support thinking skills, to in turn help people return to meaningful activities and life roles. So I was first introduced to Jess online, and that's part of a lot of research and information that you've all received through email. So that was the research that Jess is doing as part of her work with Monash University. So she'll talk about that. And we do have quite a few, I think a couple of people who are joining us today who are part of I think it's the advisory group. Is that right? You'll talk about that, Jess, so I don't get anything wrong. But now what I'll do is first send us over to Jess, and I'm going to stop sharing my screen and now make Jess the official host of the meeting. So her technology will start working, hopefully. Okay, Jess, you are now the host. Hopefully that allows you to share your screen.
Thanks, Simone. All right. Before I kick off, can people see my screen? If those can give me a thumbs up, that I can see the pictures of. Beautiful. Thank you. Well, firstly, I just want to say thanks to Simone and Brain Injury Association of Tasmania for asking me to come and have a chat today. Whilst the title and the things I do sound long, I like to keep things relatively informal. Of course, I'm going to talk today, but also, Simone, I'm getting notifications to admit people. Are you happy for me to do that?
Yes, please do. But one moment, we can't see your screen.
Oh, you can't see my screen?
Can you sit on that one? That's so weird.
So people online can see my screen, but not people in the room. Oh,
everyone online can, but we can't in the room. It's somehow still sharing my screen. Sorry, everyone.
Okay. Simone, maybe you didn't need to assign me as the host because I could share before. I wonder if that has something to do with it. Do you want me to?
Better.
You've solved it?
No, it's working now.
Okay.
I think it's because I have my screen playing. Sorry, everyone. And Bianca said that she can also see it. So we're all good.
Okay. Well, I just wanted to say thank you very much, as I said, and I will speak today, but really try and pop your questions in the chat or jot them down to help you remember them, because it's more about the discussion that we have at the end, which is often the most helpful part. And some things you might want more detail on, I've kind of just pitched at a certain level, and I'm very happy to do that as well. So today, I'm really going to talk about a project that we're running, a research project, which is about trying to improve care and rehabilitation after traumatic brain injury across Australia, which is no mean feat, but there's a bit of background I'll discuss before I get there. Well, Simone did a beautiful welcome to country, but I quickly also want to acknowledge the traditional custodians of the various lands of which we're all on today, given we're meeting online, and any Aboriginal and Torres Strait Islander people that are joining us as well. So, oh, Simone, there's so many people joining. I'm just going to keep clicking admit as I speak. So Simone asked me to, I guess, talk about a few things today, but firstly, my background of how I arrived to be doing what I'm doing. But before I talk about that, I'll tell you who I am, because we're all people first and foremost. So I'm Jess. I'm a family member, a wife, and a mum of a very chaotic 4-year-old child. I actually just moved house yesterday, so this is a really, really pleasant distraction from not being packing boxes right now. I like good food and trying to do yoga as well. But professionally, I'm actually an occupational therapist and a neuropsychologist, and my passion for work has always been in brain injury rehabilitation, particularly when people get out to living in the real world, in the community, even though I've worked in the hospital system as well. I've had a bit of a pivot, and I'm working in more of an academic role now at Monash University in Victoria. And my job here is to train the next generation of neuropsychologists, particularly in rehabilitation, and also to conduct research, which I'll talk a little bit about my passion for research. But the pivot that I spoke about really happened because I got to a point where I'd be working clinically. It was great and very meaningful, but I really wanted to affect change on a bigger level as well, rather than with the one-on-one. And I was noticing probably some gaps and things that I thought could be improved in brain injury rehabilitation from the care that was being provided by clinicians and hopefully the outcomes for people with brain injuries. Now, that's a very ambitious thing to think to do, but the way that I thought I could do that is to try and help equip these upcoming clinicians with skills in rehab after brain injury, and also try and conduct some kind of what we call clinical research to try and improve care. So this is often a chipping away process, but hopefully there's good things to come, and we'll talk a little bit about that today. So these things here are not new to any of you, but today the project that I'm focusing on the end is about traumatic brain injury, which is a specific type of acquired brain injury. And when we talk about acquired brain injury, that's a bigger umbrella term, which includes things like stroke and hypoxic injury. This is really about TBI today because that's where the current project is at, but a lot of this applies more broadly as well. So, after people have a traumatic brain injury, they notice or they can experience a variety of changes. Now, some of the most common changes that people experience and report themselves and are noticed by their loved ones and clinicians are things like how they and how their body works. And that's all completely understandable because their brain has suffered an injury, therefore causing changes in these functions. And these are multiple different things that can occur. And today we're not going to focus on all of these. We're going to focus on a few different areas. So today what we're going to focus on is the thinking skills, which clinicians like to call cognition or cognitive function. How many, if we can get a hands up, how many people have heard that term cognition before of those online? Yep. Okay, most that I can see. All right. So that's what clinicians like to call it, but it's just a fancy word for thinking skills, really. And then we'll talk a little bit today, that's where we're really going to focus on cognition, but also on the feeling, that how people act. So this is things like behavior, maybe personality, those types of things. People might experience some changes in their identity, and also socializing there as well. We won't focus so much on how your body works today. And whilst today I'm talking about cognition, the really important thing that we all need to remember and of course acknowledge is that people anyway, or people after a brain injury, we don't work in isolation. So something's going on with our thinking skills that of course might affect how we feel and our mood as well. So whilst I am focusing on something in particular today, I want to just acknowledge that there's an interplay between how our body works, how our body moves, how it feels, our thinking skills. They're all connected, but we are going to have a focus on one today because that's obviously how we have to chip away at improving things. And all these different functions, whilst it's important to understand them and how they work for each person after a brain injury, what's even more important is to understand the impact that they're having in what is meaningful to that individual. So what does that person want to do in their life or need to do in their life? What well for that person? So what are their strengths in these different areas that we can use? And what are the things that are a bit more difficult for them that we can work on to help improve what's meaningful to them? That might be things like having a relationship, studying, playing lawn bowls. It's different things for different people. And so whilst we're talking about the difficulties before, I guess I just want to acknowledge that it's important to think about why we want to understand them, and that's to improve the things that people need to do or want to do. So I've just kind of bandied around these terms of cognition and psychosocial functioning after brain injury. So what do clinicians mean when they use these terms? So psychosocial functioning is quite a big umbrella term, and this is things like your social skills, how you act, your emotional well-being, substance use like alcohol and drugs, sleep and fatigue, and sexual functioning. So what does this mean in your day-to-day life? This means things like socializing with friends, possibly getting frustrated more easily, like your threshold just isn't as big as it used to be, feeling low in your mood or more anxious, possibly misusing alcohol or drugs, trouble sleeping or with being really tired. Fatigue is really common after traumatic brain injury. Changes in intimacy or sex, for example. So these are just some areas of psychosocial functioning. And the reason I'm kind of raising these is the project we're going to talk about at the end is going to try and improve the care and the outcomes for people who experience psychosocial difficulties or changes after traumatic brain injury. The thing that I'm really passionate about is cognition. So this is thinking skills. And this is where my marriage of occupational therapy and neuropsychology come together, because occupational therapists are kind of focused on the doing, the functional part, and neuropsychologists are really focused on, I guess, understanding what is going on and then the strategies that can be used to try and improve things. And then occupational therapists focus on the actual doing or execution of that part. And so whilst it's called cognition, I like to call it functional cognition. So it's kind of like thinking skills in the real world. So what do I mean about that? I mean something like, I really like to go to the football. I'm a mad Collingwood supporter. So if I'm going to go to the football, I actually need to think about things that I need to do to get there. So planning, organization, problem solving. What time do I need to leave? What time do I need to, I need to arrange with my dad where we're going to meet to go to the football, who's going to have my daughter while I'm there, etc. So they're executive functions, which is one type of cognition, which we'll talk about in a sec. But what I'm trying to show there is that it's based in real life function, but I needed to use a whole lot of planning, organization skills to work out how I'm going to get to the football. So your thinking skills are things like concentration, so paying attention, being able to sustain the focus, not paying attention to something that's distracting when you need to pay attention to something else, like a conversation, or being able to do two things at once, which can be really tricky. It's about how quickly you can think. It's about memory and also the kind of complex thinking skills that I just spoke about, planning, problem solving, organization. And that's like the CEO part of the brain, like the big boss that controls everything. It's kind of top down and does a lot of the trickier thinking. I'll talk about that a bit more. So let's dive into cognition and what we actually know about cognitive functioning after someone has a traumatic brain injury. So I guess because of the nature of a traumatic brain injury, where someone obviously sustains an injury to their brain, but also the areas that are commonly impacted in a brain injury, acknowledging every brain injury looks very different. Because of that, people are at, high likelihood of having changes to their thinking skills after that, because of the nature of the brain injury itself. Now, the main ones that we just spoke about, I gave you the terms that I like to use, but these are the kind of, I guess, fancier terms. So it can be things like attention, speed of processing. So that's how quickly you're thinking and processing information, your learning and memory, and your executive functions. These are the thinking skills that are most commonly impacted after brain injury. There are other thinking skills that we obviously have, like our visual and verbal skills, etc. But these are the ones people most commonly experience changes in because of the nature of the brain injury. But this is going to be different for every person. Now, what we know after the injury, obviously itself, is we have a lot of great recovery that happens naturally, also through hard work, clinician input, family support, etc. But what we tend to see is that cognitive changes or thinking changes can persist over time. So I don't know if this has been an experience for many of you, but often the focus of rehab in the earlier days is on the physical symptoms. So getting up, being able to walk, talk, etc. And often it isn't until the later stages that rehabilitation starts to focus and address on the thinking skills. And that might be if people get the services that they need, or the support, is available to them. And that's not always the case, is what we now know, and is really unfortunate, obviously. But we know that a lot of physical changes improve quite rapidly in those earlier stages. And so do cognitive improvements are made too in those earlier stages, but they actually persist for a longer time. And they're quite enduring, the difficulties and changes in our thinking skills, and they can have an impact on real life living in the community. So whilst they're often not getting the airtime and the focus that maybe someone like me who really likes cognition thinks they should earlier on, they're also probably still under addressed longer term. And what we now know from the evidence is they persist and they really impact important things for people with traumatic brain injury. The other thing that we know, which I'll talk about in a second, is that there's a lot of gaps in the rehabilitation and care people are getting to help improve their thinking skills to do the things they need to do. So we spoke a little bit about attention, speed, learning and memory, and executive functions. But like I said, what's actually important is the role that they're playing in real life functioning. And so that's why often when you're in a hospital setting that's like nice and contained and everything happens quite systematically, sometimes the changes in our thinking skills aren't so obvious. Whereas when we get out into the real world and things come up that maybe you don't expect, or you're having to be more independent, that's when sometimes these changes in thinking skills can become more apparent. And this is where we really need them. So if someone's trying to get back to work, there's a whole lot of different thinking skills they might need when they're in their job, depending on what that is. Or if someone's had a brain injury and they have a child that they need to care for, they have to use a range of these skills as well. Like they might have to remember that, oh, this child has a fancy dress party on this day. So it's a memory thing. I've got to plan ahead and get them a costume. So that's the executive functioning part. And then on the day of the party, I've got to follow the conversation with the other parents, which is attending and processing speed and being able to take in all the information. So this is where the actual cognition in day-to-day life really comes in. Obviously, everyone with a traumatic brain injury has a lot of beautiful strengths still in their thinking skills, and we need to draw on those and use them to help compensate for the difficulties that they experience so they can do what they need or want to do, as I said before. So why do we do rehab? To support kind of these different areas of functioning, in particular cognitive functioning. Now, it's not as straightforward, the rehab, as say like rehab for a broken leg, which is very clear. We're going to do this certain intervention for this many weeks and then it will be healed. As you all know, the brain is incredibly complicated. What we know about cognitive rehabilitation is that it needs to be individualized for the person, and it needs to be driven by the goals that they have for what they want to do in their lives. Obviously, if things are meaningful, we know, and the evidence tells us this, we have better outcomes. And then the clinician brings their skill set in understanding cognition and the strategies that can be used to help the client achieve their goals in a way that works for them, considering their cognitive strengths and cognitive weaknesses. So now that all the researchers around the world understand that cognition and thinking skills are actually really important for people longer term living with a brain injury, there's been this huge surge in research in cognition and cognitive rehabilitation all around the world of late. And it's a growing field with huge numbers of kind of studies going on in this area now, which is really good to see because it was kind of reasonably quiet for a long time. Even having said that, though, we have huge gaps in our research, so our evidence-based care, and this is just slowly being chipped away at so that clinicians know what is kind of best practice and how to implement that as well. So for example, we have these things called clinical practice guidelines, which help guide clinicians as to the best evidence of approaches to use. And that was kind of put together by a team of researchers all around the world. And they're really helpful, but there's still a lot of gaps there. And a lot of those recommendations are made from expert opinion because there's not actually evidence yet to support them. But we know as clinicians that they're things that work for people. Where another gap is in the research is there's a bit of a lack of understanding of the consumer perspective. So, you know, I guess in the old days, research used to happen where academics sat in an office and kind of said, like, this is the right thing to do, this is how it will work. But then when it came to translating that into real life, it's not always practical. So now we know that we need to partner with the people that use this. So that's actually clinicians who are working on the ground. It's people living with a traumatic brain injury, and it's their close others and their family members, because you have the lived experience and you have that knowledge and expertise. So it needs to be a partnership between clinicians, researchers, consumers themselves, and bringing together all those expertise. Excuse me. And that's one thing our project's trying to do, to ultimately improve the care that clinicians can provide. Also, we'll talk about this later, but access to care. And of course, then the outcomes for people with brain injury. So when someone has a brain injury, kind of signified by this lightning bolt, obviously they're at the center of all of this, and a lot of changes are experienced for them. But I just want to acknowledge that, like we just said, that it's not just about them that we need to work. We need to work as a whole unit here, and that's what this circle signifies. So with their close others, which are these people on the screen, we need to also consider the environment that they're in. Where are they living? What do they need to be able to do in their community, etc., or the hospital environment? And then the clinicians need to come together. The reason I put this here is that we need to keep the person with the TBI at the center of it all, but we need to work together as a whole team, considering all factors for things to work. It can't just be one part in isolation. So how do we kind of go about rehab to promote cognitive functioning? So I'll talk a little bit about cognitive rehab, and then Simone asked me to kind of briefly speak about the role of neuropsychology as well. And I've just put on there OT because I can't help myself too. But in terms of cognitive rehabilitation, so this is rehabilitation to help either improve thinking skills or to address thinking skills to improve function in day-to-day life. So what we know about cognitive rehabilitation is there's lots of ingredients that are really common in other parts of rehabilitation that are important and help rehab, like assessment, goal setting, working collaboratively, having kind of a shared, I guess, formulation, which is an understanding to plan the treatment, and individualization, so catering it to the individual, their strengths, weaknesses, and needs. So that's all common to other types of rehabilitation. Then in cognitive rehabilitation, what we know kind of works well is all those things, but specific to cognitive rehabilitation is it's using what we call compensatory strategies. So strategies that help people compensate for the difficulties that they're experiencing. So for example, when I say compensatory, it's things like teaching them new ways to do things. So they might have an internal script they use in their head to help them take in information and rehearse it, or to remind them to do something. Alternatively, they might have external strategies that they use. So it's things like a phone with an alarm to remind them to do something, planning, problem solving, kind of systems and structures that they work through, a calendar up in their room, etc. So they're kind of two key types of internal compensatory strategies, so the internal ones and the external ones. And we work with the people with brain injuries to develop those to work well with them. So for example, I had a gentleman that I was working with who was trying to get back to work, which people hadn't expected was going to happen, but it was. And he had a lot of difficulties paying attention and taking information in quickly in the moment. yet he was kind of really didn't really want to use external strategies, which other people kind of could see. He felt they weren't his normal, even though a lot of people use them in day-to-day life. So we had to develop some internal strategies that he felt were kind of acceptable in his workplace. So, you know, at the end of a conversation, a hallway chat with a colleague where he was actually kind of given something to do, he'd say casually at the end, "Oh, okay, so can you just clarify the key 3 takeaways from this chat, just so I make sure that I can execute them after today?" And he felt that was really kind of acceptable in his workplace. But what it did is it might have been a 10-minute chat, and it summarized the 3 points that all he needed from that chat, and he could actually retain them till he got back to his office and jotted them down. So it's about working with the individual to kind of plan those strategies that work for them and what they need to do. So that's kind of this compensatory type of strategy, and we find that they work well. There's another type of cognitive rehabilitation called remediation, where they're actually it's a restorative approach, trying to actually repair the impaired kind of function after the brain injury. What we know is there's some elements of that work really well, like repeating things over and over. The more you repeat things, the more automatic it becomes, the easier it is to do. But practicing something on repeat over and over, which actually isn't kind of linked to the real world or the thing that you need to do, sometimes isn't as helpful, because then what you've got to do is you've got to work out how to use that strategy in the actual task that you need to do. So whilst it's doing no harm, doing something, you know, like brain training or something like that, it's just about thinking, how am I going to actually use these strategies in day-to-day life is the main thing as well. So yeah, that's kind of a few, very briefly, I can chat more in the questions about what we do about cognitive rehabilitation. We have different strategies that we use for different areas, but it's all within this kind of individualizing it to the person, being goal-driven and working collaboratively with them as well. So the role of neuropsychology is neuropsychologists are experts in brain behavior relationships. So when there's something that has happened or is changed within the brain or going on, neuropsychologists are particular experts in cognition, so thinking skills, behavior, how we act, and also emotion in the context of these changes to the brain as well. Neuropsychologists traditionally have done a lot of assessment with people, so assessing cognition, particularly strengths and weaknesses, to understand, in this case, the changes, and put that all together into what we call one formulation, which is really the understanding. It's like the puzzle. Hey, you're saying that you're having trouble, you know, grocery shopping because you leave without the things that you wanted to get, and you've bought all these things, you know, you don't need, etc. Oh, the reason this is happening is because these are the strengths and weaknesses that you're having in your thinking skills. So they're kind of like explaining and giving understanding to what's happening in day-to-day life. The important thing about that understanding is it helps plan for intervention. It helps go, well, these strategies will work for these people because we know that they're really great with their visual memory, but, you know, remembering information verbally is a lot trickier for them, for example. So that's where this understanding, or formulation as we call it, is really helpful. And now neuropsychologists are playing more of a role in the actual treatment as well. So delivering interventions and developing them with with people with brain injuries too. But they obviously have to work within a bigger multidisciplinary team. And acknowledging that neuropsychology is a reasonably small profession. I know, you know, there's not a whole lot of neuropsychologists in Tasmania, for example, is my understanding. So that's why I just wanted to highlight that there are occupational therapists who are amazing at kind of functional cognition too, and the actual doing part of things. So working out how you can do things in day-to-day life in a way that works for you, considering your thinking skills, be it cooking, shopping, whatever it might be, studying, etc. So they're based more in that functional space as well. But yeah, neuropsychologists have this really, I guess, fine-grained understanding of cognition. It's kind of their bread and butter, and so can be really helpful in providing some input and maybe even consultation to the team if there's not enough of them to go around to provide the actual hands-on intervention as well. So the research that I do, my research is through Monash Epworth Rehabilitation Research Centre, so a partnership between Monash Uni and Epworth Hospital, which is one of the main brain injury rehab centres in Melbourne. And this research centre is led by Professor Jenny Ponsford as well. And so just to highlight that MERC, as it's called, has a lot of great projects going on that you can be involved in. It's really focused on, I guess, well, Jenny just said to me this morning, her life passion is on implementing research to improve care. So it's about not just doing research for scientific purposes, but actually being able to change things for the people that I guess we're here to serve that matter. So my work is very much grounded in clinical practice and my learnings in that space. And again, I'm trying to improve care and then outcomes as well. And, you know, I like to do my research kind of from a co-design perspective, which is really about a partnership with clinicians, service providers, people with brain injury and their families. And Bianca, I hope it's okay to call you out here, but on the project that we're doing now, we have what we call our LEAP. So it's a lived experience advisory panel, and Bianca is one of those extremely important members. And I have a couple of emails that I need to respond to from Bianca while I was on leave, but really partnering and giving us really helpful insights. So for example, we're conducting surveys with people with brain injuries at the moment and their close others, and Bianca and our other members really provided so much important input into how we developed those surveys. No, don't word that question like that. That doesn't make sense. That's not what you're trying to get at. You need to word it in this way. And so you can see how it's a real partnership because they understand that perspective. They're the experts and we're not. And my focus of topic, I guess, in my research is about early recovery. So I don't know if anyone recalls or has heard about post-traumatic amnesia before, but about trying to get people to have rehabilitation during this stage of recovery, and also about cognitive rehabilitation. So interestingly, we've just finished writing it up, but we did a survey of cognitive rehabilitation practices internationally. And this is kind of what's sparked all this work that we're doing. And we found out that we had over 600 clinicians and complete the survey that we could use, and less than 40% of them felt that they were sufficiently trained to support people's cognitive functioning after brain injury, despite them all being people that work in TBI rehabilitation. So it's quite alarming, quite sad, and it's something that we need to make sure that we are providing the resources and the training for, so that people with brain injuries can get the best care. So that's something that we're doing now, and we've actually gone on to interview clinicians all around the world to get a more in-depth understanding as well. And we're now trying to actually develop some interventions to address the gaps there, which I'm happy to talk about later. But just briefly, kind of to start wrapping up, what I wanted to tell you about today is the project that Simone mentioned, which is this project here, which is about implementing evidence-based care for cognitive and psychosocial difficulties after traumatic brain injury. Now, this project is an Australia-wide project being led by Professor Jenny Ponsford up here on the screen. So we have investigators from all over Australia working on this project. From Tasmania, we have Dr. Cynthia Honan and Dr. Claire Ramsden, who some of you may know, who are contributing to the project. And from our lived experience advisory panel, we have, gosh, apologies. I've got Cynthia and Claire's name there. That's meant to be Bianca and Paul as well from Tasmania, who are invaluable members. But this project ultimately is a big vision to try and improve the lives for people with TBI. The project has 3 main stages: explore, design, and implement. And I'll tell you about those in a second. And targeting the various areas we've spoken about today, psychosocial and cognitive functioning. And there's particularly priority populations that we've addressed. We really need to make sure that we're improving resources and services for. So those living in rural and remote areas, culturally and linguistically diverse people, and Aboriginal and Torres Strait Islander people as well. So I'll talk a little bit about the explore phase, but before that, why are we doing it? Well, we know that where we're at with clinician practice and the resources they have, and we're trying to further understand now their needs and gaps in that area. And what we also need to understand is consumers' needs and wants, so people with brain injury and their close others, And then we bring that all together to try and bridge the gaps that currently exist to improve things. So we're currently in the explore stage of this project. And really what that is about hearing from everyone around Australia any stakeholders involved in traumatic brain injury care. So these are clinicians, people with a TBI, and family members or close others. We really want to understand what they're doing, what is their practice, or for consumers, what they received. What do they see as the key gaps and priorities, and any kind of suggestions of how some of those could be bridged. So that's the key stage in this explore stage, that I'm leading this part of the project, but with the investigators from all across Australia. So how we're doing this is in a two-step process. One, we're doing surveys, and then two, we're doing interviews where we kind of discuss things in a bit more depth, the things that the people that we're speaking to think are important, whereas the surveys are more overarching. For the surveys with people with the TBI and the close others, if they want, we actually do the surveys with them over Zoom or phone, and we found that's been going really well, and we've been gathering really, exceptional information that's going to be so important in the next stages of the project. So far we have done, I think, just over 30 surveys with people with a TBI. Carly will know the numbers better than me, and a bit less with close others. And we definitely want to try and increase the numbers and reach to make sure that we can hear people's voice to address their needs, to provide better resources and better training at the end of the day as well. So that's the why. After this explore stage will come the design and implement stage. And Jenny Ponsford, obviously, who I said is leading this project, is, this is an amazing vision to try and design, I guess, training packages, care pathways and resources to meet the gaps that we've learned about in Explore. And then implement just means roll it out. So actually make it happen in the real world. The way that we usually do that is in a couple of stages. So one, it's about trialing it in a few little sites first, getting feedback and refining it before we then roll it out on a wider scale as well. So I guess what I wanted to flag today, because I'm right on my 30 minutes that Simone said, was we would love to hear your voice, because without it, we won't be able to capture your needs and perspectives and be able to help improve things, also hopefully for you, but for the people to come as well. And so I'll get Carly to pop the links in the chat as well. But just so people with a TBI and close others know, this is not consenting to the research at this stage. All as it is just expressing your interest. So saying, hey, I'm interested in to hear a little bit more about this. And what happens is one of our lovely team members calls you and discusses the project and provides more detail. And then you can make an informed decision if you want to participate in the survey as well. Obviously, this all has ethics approval across Australia, and all the information is completely confidential. And the information provided is then made anonymous too when the research is all put together overall. But the consumers that have been doing the surveys have really actually reported it to be, they've really enjoyed taking part in it, and we're actually getting a lot of emails and calls saying, hey, when is our interview? We're ready. We want to keep going with the research after they've done their survey. So it's been a positive experience, and I think that's because of our LEAP panel who help us design these surveys as well. And also my research team here, they're almost neuropsychologists, so they're all really lovely people, and I think have a great approach to talking about some things which can be tricky at times. So we'd love to hear from people with a brain injury, but also their family members. And you can pass this information on to anyone that you know as well. You have the okay for this to be passed on and forwarded on. Similarly, if we've got clinicians here today, we really want to hear their voice and make sure we capture their input into their needs and wants and gaps. And also, I should say, what is going well, because we want to make sure we keep those things happening too. And so this is the survey for clinicians as well, which is the direct clinician survey link. So I guess, putting it all together, we know quite a bit about brain injury and cognition and thinking skills, but really we need to hear more from the users to be able to continue to improve care and rehabilitation across Australia. particularly in cognitive rehabilitation, which is my passion to, you know, really make things work. And so I think ultimately we need to work together as a partnership to be able to do that. So thank you. I'm going to now open it up for questions, Simone, if that's okay.
I'm on mute and was talking to everyone. Yes, yeah, definitely open it up to questions. I think we've already got one that's come in the chat. Not sure if you can see that.
Oh, do you happy for me to work through them? Yeah.
Yeah, no, I can read it for you. Is this only applicable to people with TBI and excludes ABI persons?
Yeah, that's a great question. So this project, unfortunately, I guess the way often funding for research works, you have to try and go and get grants for projects, is that they kind of can target specific populations. And this one is for people with a traumatic brain injury. So technically they call it moderate to severe traumatic brain injury, but I guess people who've had other types of acquired brain injuries, we do have other projects running at Merck. So feel free to email our study email address if you're interested in taking part in research, because we do have other projects running, which include ABI more generally.
No, I'll just double check my room. Does anyone have any questions in the room? No one? No? No? I don't have any questions in the room. What about anyone online? Everyone may be on mute, so if you can always pop it in the chat if you have any questions. Any of the many Simones.
Yeah, it's hard to understand.
Oh,
post-traumatic amnesia.
Yeah. Sorry, you can see that.
Yeah. Absolutely. So the PTA or research that we do is really about trying to improve care during PTA, which is the early stage of recovery after traumatic brain injury, where people have difficulty with their learning in particular and their orientation, where they are, what's happening, and they can display other things too, like agitated behavior, and all their kind of cognitive thinking skills are often really quite difficult during this time. And people do have a lot of natural recovery after PTA. Traditionally, what's happened is people during PTA have kind of been left to rest and recover, but we don't actually know if that's the best thing to do. So what we did actually at the start, that was in my PhD, this is when we started this body of work, was trying to see if people can actually start active rehabilitation during this stage of recovery. So we worked out that people can actually engage in skills retraining during post-traumatic amnesia to improve their independence and things like showering, getting dressed, even basic meal preparation. And that was shown to be really beneficial, and people did improve faster during PTA and up to hospital discharge as well. So what we're actually doing now with this research, we have a current PhD student. We have done focus groups with people with TBI out of PTA, their close others and clinicians all around Australia to understand the next gaps and needs within PTA care. We've just kind of concluded those recently, which has been amazing. And now we're up to the stage of designing the intervention. So that's actually one step ahead of what we've just talked about today, designing the interventions or the innovations to deliver that. So one of those things that was addressed is education and information provision to family members about understanding PTA and how to support their loved one during this stage. And this is something that's the next step of that project, but we've got lots of arms of things we need to innovate to deliver around Australia there. But we are actually including that within the current project that I spoke about today, because obviously post-traumatic amnesia is an area where cognitive recovery is the key thing there. So PTA is something that we're including within this bigger project as well, to try and improve the care that's provided there to the person with the TBI, the information, education, and also we're hearing involvement of the close other, and also clinicians feel they need better training in this area of care as well, because it can be quite tricky for them, is what they report, given I guess the lack of specific education in that area.
I'm not sure if you can see, Jess, but Charlene's commenting that during Rowan's 7 weeks in PTA, she was told that he needed to rest and recover in the quiet and dark. but she played music, talked to him, and walked him around the hallway. So it's interesting to hear that her approach was okay.
Well, we're hearing
Good to
from
hear.
family members. I mean, it's something we're hearing a lot at the moment in this current project is, I guess, you know, even just focusing on the person with the TBI is, you know, more of a recent thing. But now, like, we're hearing that, unfortunately, the family members are often, I don't want to say the forgotten ones, but there's not as much, you know, support for them at how do they support their loved one, but also how are they supported? And so that's something that we're working on in this project as well, because we see it as key. They're obviously part of the team that we showed here.
Great. And I did see, I'm not sure, Jess, if you noticed, throughout your talk, Bianca was just asking if maybe you know of any research papers, TBI research papers or citations that we could maybe send to people that you've referred to in your presentation, and I can send it along.
Yeah, absolutely. I'm sure. Yeah, absolutely. The guidelines, I guess, are probably so there's these group led by Mark Bailey in Canada, and this is getting a bit academic, but he has led this team called INCOG, which is International Cognition, really. And Jenny Ponsford's one of the other leads on that. I was fortunate enough to be invited to contribute to one of these as well. But so there's these INCOG guidelines, and what these group of experts do all around the world is they look at all the research that exists, how good that evidence is, so the quality of it, and also as experts and clinicians in the field, what else does the research not tell us that we think we should be doing, even though the research isn't quite there yet? And then they put all of that together into guidelines, and they kind of rate the level of evidence, how confident they are in that recommendation that they've made, depending on the level of evidence. So if it's just come from expert opinion, that's kind of rated level C, where if it's from this really big research project that's, you know, evaluated it comprehensively, like we'd say in a randomized control trial, that would be a level A recommendation. Now, those guidelines are called INCOG, INCOG 2.0, but yeah, happy to kind of share those. And they have a nice, there's about 6 papers in that series, but they have a nice kind of overview paper, which gives you your overview of cognitive rehabilitation and the core principles of it that we spoke about. Like, there needs to be goal-based, needs to be what the individual wants to do, incorporate the strengths, etc. Average time frame that neuropsychologists usually work with patients. Yes, I think this is individualized. I mean, I think that if someone with a brain injury has a goal and that they want to do, and they're experiencing some difficulties achieving that, or even if they are able to do it, but it's not in the most kind of functional, practical, you know, efficient way they want to, it shouldn't be kind of given a time frame. So we're pretty lucky in Melbourne. Our system is based on if there's a goal and a need, generally we can get funding, and that's what it should be driven by. And that's what I'd always urge you to advocate, because life happens and transitions happen. And so the person might be going fine, and everything's going well, and they're managing with their strategies in day to day, but now I actually want to get back to work, or I want to get back to study. I've got a new life goal. My thinking skills are going to make that trickier. So therefore, you know, getting a neuropsych in to support that would be great. Or even if they just did an assessment to inform the steps thereafter, that can work well too. Thanks, Bianca.
Now, are there any other questions? Oh, no, any other questions? Anyone in the room? Oh, yes, sorry. Yes, we do.
Please go for it. I love questions.
That's okay. Mine's ABI, not so much.
That's fine. Bianca, can you just unmute? I mean, Simone, can you, unmute her?
I need to unmute the other computer. Hold on.
Okay.
Can I try again?
Yeah. In other words, I'm interested in ABI, you know, looking into that. In other words, there's a difference between ABI and TBI.
Well, sorry, it's just a little bit hard to hear, Simone. Was it if there's a difference between ABI and TBI? Was that the question?
Yeah, probably.
Yeah, what we know is people with depending on the type of ABI, if it's stroke, lack of oxygen, a tumor that's been cut out, etc., we know that there's different patterns of difficulties that people are, depending on the type of ABI, have. Now, that's a big generalization. So people with a stroke often, because the area of the brain that's impacted is more, I guess, specific and located, they'll have a certain pattern of difficulties based on that region of the brain and the circuits that kind of run through there. Whereas with TBI, it kind of can be a bit more, I guess, diffuse and spread across the brain, the areas that are impacted. So often it's a different pattern of behavior. Like in stroke, we might see more language or visual changes depending on the area than we might see in traumatic brain injury. So at, I guess, what you'd say, like the impairment differences. But when we zoom out and think about what the people actually need with an ABI, that's where we see the similarities. So all the things that we're talking about in terms of what works, we actually have evidence for cognitive rehabilitation, which is great in both stroke and in TBI. And the principles of it are exactly the same. And so that's where we need to obviously be putting all of this together to be able to improve care. And so whilst this project is TBI specific, I imagine that there'll probably be a zoom out and generalization at some point, but acknowledging that there's different patterns of difficulties that underpin it. But I think how you approach it is the same. It's just targeting different areas. Don't know if that answers the question.
I'm just switching things around. Did we have any other questions in the room? Yes, we do.
We spoke a little bit about this gaps work on the ground. I'm kind of wondering, give us a little bit more depth in regards to that and what you've been in order to kind of get this research project. What's kind of that feedback?
Simone, I'm so sorry, I can't hear the room.
What was that?
I'm so sorry, I can't hear that wonderful, I'm sure it was wonderful question. Would you be able to relay it up near a mic? I'm so sorry.
Let come up here.
Sure.
Sorry.
Can you hear me now?
Let's give it a go. I'll hear.
Should be that one.
Okay. Yeah, so my question was, you spoke to the clinical gaps.
Yeah.
And I'm just wondering if you could dive into that a little bit more and what you've kind of seen in that regard.
Yeah, that's a great point. Actually, I guess coming back to those guidelines of recommendations for clinicians, they were just updated. That's why it's 2.0 in 2023. And that's where we've really seen that there are gaps in the kind of evidence. And then we also know that there's gaps in clinicians' practice. So we've got two kind of areas of gaps, I guess, clinically that we're talking about there. And then, of course, understanding consumers' perspectives, which we've already spoken about. From an evidence point of view in cognitive rehabilitation, whilst it's a hugely growing field, there's not a lot of really high quality big studies that we can really hang our hat on. And whilst they're coming, we want more of them to know what to do. The other thing that's tricky is often, as needs to happen in research, it's quite specific, you know, like people that they're doing it with or a certain strategy that they're evaluating. Whereas in the real world, we want to be able to put it, you know, not just evaluate a type of strategy about attention. We want to be able to think about it all together, because like that example, I don't just use one thinking skill, I'm using 3 types of thinking skills to execute that plan. So that's one area that we need to keep working on, kind of actually formally.
I'm not sure if Jess is frozen for everyone. Might need to. Yeah, okay, so yeah, we'll just give Jess a moment. Hopefully her internet reconnects. Yep, okay, cool. She'll just probably, I think, be logging. Oh no, Jess, you're there.
I'm so sorry, I don't know what happened. I will quickly answer this because I know we're at time. I was rambling on, but I guess one of the other things is, I was just speaking about the guideline gaps, but then also something that we learned from our survey is obviously clinicians feel undertrained, underskilled, and under-resourced in cognitive rehabilitation, and they're telling us it's actually a complex area of rehab. And so something that we kind of found out from there is they obviously want more training, but there are strategies that they use, which I think make complete sense to help people with brain injury, and I would use them too, but there's actually very little evidence to support them. So now we're going the other way too, and we're trying to learn from, well, this is what clinicians do. Let's try and formally evaluate that. So one of those areas that we're looking at is, I guess, what you'd call environmental adaptations to support cognition. So it's a type of external strategy that I was talking about before. So it's like, how can we either change the task, the setup around the person, or even bringing in a support person to prompt them and support them to help their function and independence in day-to-day life. So I think clinicians, the 600 that we surveyed around the world, 88% of them said they were using environmental approaches, like often or always in their practice of cog rehab, but there's almost no evidence to support that. And we want to know this is the best practice, it's evidence-based, and then train clinicians in delivering that as well. So that's one of our missions. That was a great question. Thank you.
Oh, we're not even on mute. That's great. Did we have any other questions in the room? No. Is there anyone online that has any questions? It doesn't look like we do. Okay, great. Jess, did you have any final comments before we?
No, I just wanted to say a huge thank you to everyone. It's so good to be here. And Carly, I'm just copying what Carly put in the expression of interest form, but Carly, can you please just put our email address in the chat as well? Carly is here. Give us a wave, Carly. She's one of our research officers who conducts the surveys with people with brain injury if they want to do that with someone. And yeah, she's really instrumental in making this project actually happen. I wouldn't be able to do it without her. So feel free to email us if you have any questions, or fill out that expression of interest form, which is just really putting down a phone number so we can give you a call to have a chat. But we'll circle back to you, reasonably quickly with at least the survey responses, and then we just want to be able to work together, I think, is the main thing. But if you ever want to chat more about any of these areas, I'm always happy to. And yeah, thanks so much for coming. And yeah, it's so great to see such beautiful kind of communities like you have created there in Tassie. So yeah, well done to you all in being part of that.
No, thank you. And we'll email everyone. So thank you so much for your time.